Okay, I can start with announcements before we begin, as a couple people are still tuning in. This is our last workshop for Women's Health Month, and if you've missed any of the others, you can find them on our website for Healthy Lifestyles, and you can still earn points for watching the recordings. You just go to your WellSteps account, and through your WellSteps, you just mark off which workshops you have watched. I will put in the chat box how to access our women's health workshops, if it'll pop up for me. There we go. So that's how you can find past workshops, and today to get your points, you'll do the same thing. You'll just go to your WellSteps account and under rewards, mark off that you've watched today's presentation. But we have Dr. Edmunds here to talk to us about women's health for all ages. So we encourage you to participate and ask questions that may be stirring in your brain for the last month, as we have sent you newsletters and done other workshops. So you can put those in the chat, or we invite you to unmute yourself with questions. But I will hand it over to you, Dr. Edmunds, have you introduce yourself and a little bit about what you do for St. Mark's.
All right, perfect. Hello, everybody. This is a very 2020 way of doing these. I do a lot of these lectures pre-COVID, but they're always in person. So we're going to give this a shot. We've done a couple this way and tend to go very well, but my focus will be on women's health for all ages, as we talked about. So we'll talk about general women's health, pregnancy, general health things, and then I hope to leave time for questions as well. Typically, I am more than happy to answer questions throughout the presentation as well. I get tired of hearing my own voice, so if you are, speak up. And I pulled up the chat box too, so if someone has a question that they type in there, I'll try to address those as they come up. We'll see how that works. So a little bit about me. I'm originally from Twin Falls, Idaho. Came down to BYU for undergrad, and my wife and I went to undergrad there, got married there, and then off to Seattle for med school, and ended up back in Utah for residency. So I'm from Idaho, she's from Colorado. We never thought we'd live in Utah, but ended up coming back for OBGYN residency and fell in love with Salt Lake City. And so now we've lived here for about 9.5 years. So I'm at St. Mark's Hospital. If you're familiar with it, there's a women's pavilion on the west side. And essentially it's the women's pavilion is first floor is a labor and delivery and NICU and breast imaging services. Second floor is postpartum, post-surgical services. Third floor is like specialty things like ultrasound and pediatrics and women's cancer care. But the fourth floor of that women's pavilion is St. Mark's OBGYN. The majority of that floor is our office. We have 8 doctors, 3 midwives, and a PA there. So we have full spectrum OBGYN care, all stages of life. I do a lot of minimally invasive surgery, laparoscopic, minimally invasive, same-day kind of surgeries, hysterectomies that people recover from much faster from because they're minimally invasive, and then a lot of OB care, deliver 15 to 20 babies a month as well. So I apologize that we rescheduled this. I ended up delivering 2 babies during the time that we were supposed to have this last week. So I'm glad this is working out today. So yeah, feel free to use the chat message for any questions. And I just want to kind of start a little bit and feel free to unmute yourself as well so that we can interact. So women's health for all ages, a lot of times there's some confusion about when certain exams are supposed to take place, when certain tests are supposed to take place. And that's because historically, Pap Smears started when someone was sexually active, even if it was a teenager, and they were every year, and we tested a lot more frequently. So does anyone know, and if this doesn't work to do Q&A, I'll just stop, but does anyone know how often are you supposed to get a Pap smear? Boom, someone said everything. Okay, we got 3 to 5 yearly, 3. Okay, so this has been really interesting because when I started doing these lectures about 5 years ago, around town, it was a lot more common that I had every year that people were saying that. But the every 3 years is the mostly correct one. Starting in about 2011, they changed the guidelines. It used to be that Pap smears were every single year. And the Pap smear, I'm going to try to speak to all ages. I'm not sure what our age is on the call, but because there's some confusion on what it is, and some women I even still get asked like, well, why do I even do a Pap smear? The Pap smear is a brush on the cervix to collect some superficial cells. And the point of that is to look and screen for cervical cancer risk. So it used to be every year, but they found that in over-testing, we often led to unnecessary follow-up tests, unnecessary biopsies, and false alarms, which can be just as very scary. You get a call that something's abnormal, and maybe it wasn't as bad as you thought. So they've shown that cervical cancer, for one, isn't something that cells are normal 1 year and suddenly you have cancer the next. It develops slowly over time. And the reason Pap smears came about is cervical cancer used to be extremely common, but back in the 1920s, Dr. Papanicolaou was researching cervical cancer, and he would take scrapings of the cervix. And this is back where it's much nicer now, but they would use a wooden spatula, for example, and they'd scrape the cervix and they'd look under the microscope. And they found that years before cancer showed up, there was something called dysplasia. Now, dysplasia is just a term we use to explain cells that looked abnormal. And depending on the degree of abnormality, you grade your risk for cervical cancer. So fast forward to 2020 now, we know that 99% of cervical cancer is caused by human papilloma virus. Human papillomavirus, or HPV, is present, or 70 to 80% of sexually active adults have been exposed to it. It's most commonly spread through sexual intercourse, but can be spread other ways as well, which is why we screen people even if they've only been with one partner. But human papillomavirus leads to dysplasia, which can lead to cancer. So when we do Pap smears now, we have a nice rubber bristled brush, so much nicer than the wooden spatula or whatever they used to scrape 100 years ago. And we do this brush right on the cervix. It still causes cramping and some discomfort, of course, and you still have to get the speculum to be able to see the cervix. But we do that and we look under the microscope. And if we see dysplasia, we can then do follow-up. Now, the reason it's every 3 years in general, and I'll talk about some of the breakdown of that, is because this is something that develops over time. And so if you've had a normal Pap smear, we found that testing you every year, you ran a risk for a false positive that led to follow-up, which usually involves a biopsy of the cervix, which is even more uncomfortable, of course. So they found that with the slow development of cancer, going every 3 years if things have been normal is justifiable. And actually, those same guidelines said if you're over age 30 and you've had a normal Pap always, you have a normal Pap and are negative for HPV, which we test for as well, some people argue you can go as often as every 5. Now, most people still stick with the every 3 years, and I think that partly is a comfort level for providers and physicians as well, that we went from this every year to every 5 felt a lot, almost too big of a jump. So most people stick with the every 3. And I saw some of our responses were every other year. Someone said that. I think what happened there is when these new guidelines came out and we went from every year to suddenly every 3 or even 5, a lot of doctors weren't sure. They were so used to this was an every year test that there became this soft middle ground where people said, well, let's do it every other year. And so that, I think, caused even a little more confusion. But good data says as long as you've had a normal Pap smear, you should get them every 3 years. And some pretty good data says if you have a normal Pap smear and a negative HPV, potentially every 5 years if you're over age 30. Now, does anyone know when we start Pap smears? What age do we start Pap smears? I'm relying on this chat box again. 30, 19, 16. And that's the 16, 18. That's because it used to be people started that early. And A. Meredith is correct, 21. So it used to be for some of these people who said as soon as you're sexually active, or I was given one when I was a teenager, it used to be that as soon as you saw a gynecologist, these things started. But we know that these same guidelines that came out nearly 10 years ago now kind of updated our thinking on this. What they've shown is the likelihood of developing a cervical cancer at less than 21 is low enough that we do not do Pap smears until someone's 21. And that's true whether they've been sexually active or not. Now, that doesn't mean we don't do STD testings or other exams as needed, but we don't do the Pap smear. And I'll take that moment to clarify. The Pap smear itself is just the cervical cancer screen, just the swab on the cervix. We would do an exam on someone younger than 21 if they're concerned about STD testing or other issues. So, but the Pap smear itself is just the one small component of the actual pelvic exam, which I'll get to in a second. So we start at 21. And at 21, and there's some of these, actually age 24 and age 30 came up there, and I'll tell you why those ages matter as well. We stratify our follow-up differently based off of age. So a 21-year-old with an abnormal Pap may be treated differently than a 24 to 25-year-old and differently than a 30-year-old. And that's because of how people react to abnormal Paps. And also the reason why we're not doing them under age 21. The younger you are, the better your immune system is. And remember, abnormal Paps, this dysplasia, and then the eventual threat of cervical cancer are caused by human papilloma virus. So the ability to clear a virus, the better you are at that, the lower the likelihood of that worsening. For example, if HPV is never cleared, then you get to be higher risk of worsening dysplasia, precancer, or cancer. So we've shown that the younger you are, and you'd think the difference between 21 and 30 isn't much for age, but the younger you are, the more likely you clear it. So some of our data, for example, comes from the fact that maybe a 16 or 18-year-old got a Pap smear that was abnormal, did not love their experience getting a Pap smear as a teenager, and didn't go back for follow-up. But then they showed up years later with a normal cervical exam, normal Pap. And that's some of that data kind of showed us that the younger women were more likely to clear HPV on their own. And as such, the cervix would heal itself and not be at risk for worsening dysplasia. But the older you are, the less common that is. So the guidelines as they are now is we start Pap smears at 21. And as long as they're normal, it's every 3 years. We only test for HPV between age 21 and 30 if the Pap smear is abnormal. Otherwise, we don't even test. So what if a 22-year-old has HPV? We don't care so much as long as the Pap smear is normal, because we think that person's more likely to clear it and never have an issue. But starting at age 30, we think you're less likely to clear HPV. So even with a normal Pap, we test for HPV. So 21 to 30, it's every 3 years. And if it's ever abnormal, we also screen it. We also then follow-up test it for HPV. And then we go down through these treatment algorithms. 30 and above, it's a Pap every 3 years, but we also test for HPV. And then people argue if you have a negative Pap and a negative HPV, you could go 3 to 5 years between. Now, with new sexual partners, there'd be new possible HPV exposures. So you may make personal adjustments with your doctor, but that's kind of the general guideline now. Now, if anyone's ever had an abnormal, the follow-up is to do something called a colposcopy. You come in, we actually put a little solution on your cervix to help dye any abnormal cells a different color, and we have to biopsy them directly. Think of it as like a Pap smear is like brushing the top of the mole, scraping it to see like, oh, is there anything abnormal? But a colposcopy is actually biopsying the mole to make sure full thickness is there anything abnormal. So because that's obviously more invasive and more uncomfortable, that's only done if the Pap smear is abnormal. And that also is flexible based off of age. At age 21 to 24, I told you 24 mattered as an age. If it's just slightly atypical or a low-grade change, then we would just repeat the Pap smear in 1 year. But 25 or older, we would do the biopsy. And that's just a matter of, is that woman likely to clear it on their own without an intervention? So although the guidelines seem a lot more confusing than just get a Pap every year, they're meant to favor women and avoid unnecessary testing and unnecessary biopsies and follow-up. So it puts a lot more weight on us as your doctors to do the right thing and follow the right protocols. But the goal of it all is to minimize intervention, which has been very welcomed by anyone having to get those, of course. Any questions about Pap smears? So start at age 21. Let your doctor remember all these random algorithms I'm running through, but every 3 years, as long as they're normal, is what I tell most people, just remember it that way. If you're ever abnormal, we go to yearly for a couple of years until we get back on a couple normals in a row. We can jump back to every 3. Okay.
Dr. Edmunds, is there an age where we can stop getting Pap smears?
Yes. So they argue age 65. Now, the funny thing about that argument is, and yeah, D. Peterson got that right. The most common age to see cervical cancer develop, and remember I said it starts as dysplasia. Oh, one more thing before I jump to that. Having a call from your doctor's office saying you have an abnormal Pap smear does not mean you have a precancer or a cancer. Typically, so a lot of people are worried, or I have people come in to see me because they needed the biopsy and they were sent from their primary care doctor. And are worried, do I have a precancer? The grade on this is, so you got a normal Pap, or you could have dysplasia, or you could have carcinoma in situ, which is a precancer, or cancer. But most of the time, I'd say 98, 99% of the time I have an abnormal Pap come back, it's dysplasia. So we're even one step away from precancer, that carcinoma in situ. So I always remind people the reason we're doing all this is we're trying to keep you 2 steps away from cancer and never letting you get any closer. But the right answer on when you can stop is they say 65. The one funny thing about that is we tend to see the biggest spikes in cervical cancer are in the mid-20s to mid-30s, and then another spike come in the mid-60s, which is kind of funny because that's often a time where we're saying you can stop getting Pap smears. I think the unique thing that brings that up is sometimes there's been change of life, either through divorce or death of a spouse, that people may have a new sexual partner in their 50s or 60s, and that's why with a new partner, a new HPV exposure, and maybe less Pap smears happening, because the older you get, the less people think they need the exam. Because I don't have a lot of people in their late 50s or 60s coming in for Paps. I think people reach that age of like, I don't need it anymore. But if you have a new partner, there could be a potential new occurrence of an HPV exposure. And so that's why we see the spike. So, but for most women, if they're in with the same partner and no changes, you can stop around age 65. Okay, if there's not any other questions, I'm going to jump to another major part of the women's health exam, and that's so obviously when you come to see your OBGYN or primary care for your women's health exam, we're listening to your heart, lungs, checking your thyroid, trying to do your general health stuff. So I'm going to set that aside as just the general health, and we're going to focus on the women's health stuff today. But the pelvic exam involves the Pap smear, but the rest of what we're doing is we actually do a skin exam externally, because the dermatologist never looked down there. Most people can't see as well down there, or not seeing any moles or things like that. So we're doing a skin exam. We are placing the speculum and then doing an exam of the vaginal skin as well. With the speculum in, we see the cervix at the top and we do the Pap smear. We then typically remove the speculum and also feel and palpate the ovaries and uterus. And the point of all that is we're looking for skin cancers on the outside, on the vulva. We're looking for changes in the vagina or at the cervix that could be abnormal, and the Pap smear helps us clarify that under the microscope. But we're also feeling for masses in the uterus or ovaries. The reason being is you can get vulvar cancer, also can be caused by HPV and some other things, but it's a skin cancer on the outside. Now that's more common in the 50s and 60s, so that would be something we're looking for even more as you get older. We're palpating the ovaries to make sure we don't feel any masses. Ovarian cancer does not have a good screen right now. It's something actively studied and researched, but there's not a great screen for it right now. Laura Burgett, you are correct. Digital exams are less effective on obese people. I'm going to come back to that on the chat message you said there. But ovarian cancer, they've studied like doing regular ultrasounds, kind of like we do the mammogram breast imaging, but they haven't really found a good, reliable, cost-effective screen for ovarian cancer yet. And unfortunately, ovarian cancer symptoms don't typically show up until it's a stage 3 or beyond, because that's when it starts to spread and cause retention of fluid in the abdomen, pressure, and other things. So, people watch for symptoms of change in urinary habits, pressure in the abdomen, or clothes not fitting. But usually by then we're advanced stage. So when we do pelvic exams, we try to palpate the ovaries to try to catch any masses. Now, the problem with that, in answer to Laura's question here, but are they less effective on obese people? Yes. And the sad thing is they're not 100% effective even on thin people. They've shown that, unfortunately, on digital exams, we maybe only catch about 50% of ovarian cysts. The good news, though, is most ovarian cysts are benign and resolve. So we're trying to catch bigger masses, big, obvious things. But unfortunately, when someone's obese, it is harder to feel. It's hard to do abdominal exams and feel the liver and spleen and other things as well. So obesity makes most exams, not just gynecologic exams, but most exams harder. Okay, so there's a variety of things. But the other thing we're doing this women's health exam is, of course, breast exam. Do people know, when should you start getting a breast exam? When should you start doing your own exams? And then when should you start the mammograms, the actual images? Let's hear some feedback on that. Oh, I'm losing attention. No more replies.
Well, I actually have a question. So I do
Yes, go ahead.
know that, like, I've heard 40 to 45, but in our family, we have a lot of breast cancer. And so should you be getting checked at a younger age if you have a lot of family members that have dealt with breast cancer?
That is a great question. And yes, depending on the age. So let me kind of go through. As far as self-exams, I actually like that some people wrote 12, 14, and you're talking about those younger ages. The reality is we're not so much teaching like this. Some of you may remember getting a card to hang in your shower or other things that teach you how to do a detailed breast exam. We've shown that wasn't that great of a public health effort, other than to make people aware, because some women have lumpy breasts, some don't. And so there's changes, and there's a lot of confusion on what am I supposed to be feeling for. So a lot of the women I see every day in the clinic, I say, do you do an exam? All the time I hear kind of, but I don't really know what I'm checking for. So what we teach people is you should have regular, like, breast self-awareness. That's how I like to explain it, is know what your breasts feel like. And pay attention. If you have a mass that is getting bigger, hard, stuck in place, changing, then don't ignore it. If it's puckering the skin in, or if you have any nipple discharge, none of those things would be normal. And let's say you were just at your doctor's office 6 months ago and they said your exam's normal, but now you get this mass and over a month or two, it seems like it's getting bigger or changing, then you should get it checked out. So I always tell people, if you have bigger, harder, stuck in place, or it's distorting the skin or tissue, go get it checked out. Now, the reality is, the younger you are, the less likely you are to have breast cancer. I have a handful of patients that are under age 30 and had breast cancer, or really under age 35 and had breast cancer. A little bit more as you get older. 40 and above, it starts to go up. Each decade of life, your risk goes up. But as far as self-exams, it's just breast self-awareness. Pay attention to changes. If you have a lump that comes on mid-cycle when the breast might be tender, but then it goes away, that's not something to worry about. But if it's persistent and growing and changing over time of more than 2 months, then I would go get it checked out. As far as exams by your doctor, they recommend breast exams start by the medical professional at age 21. Now, between age 21 and 40, they say about every 1 to 3 years you should get examined. And how do you decide 1 versus 2 versus 3? That's usually between you and your doctor. So I always let my patients know, here's the general guideline. Every 3 is probably fine for most people. Now, most of my patients say, well, I'm here in your office. Would you just tell me if everything's normal? And so we do. But we have that frank discussion that, hey, if you're 25 or 30, it's unlikely we'll find something, but let's talk about it. And a lot of times it's why I'm teaching them how to do exam, just the same way I just explained it to you guys. Now, some exceptions to that would be if there is a strong family history, it's really easy to say, well, let's check every year. As far as the should you start mammograms early, I see a few correct answers here. Someone said 10 years before breast cancer in the family, and that is correct. 90% of breast cancers are spontaneous, meaning not genetic. Only about 10% of them are genetically related. But if someone in your family, a first-degree relative, has had breast cancer younger than age 50, let's say someone had it at 45, then yeah, we would subtract 10 years and we'd start your breast imaging at 35. So that's correct when Rosalie said 10 years before breast cancer in the family. But like I said, most breast cancers are not genetic, and most breast cancers are over age 50. But the general answer historically for mammograms and people who aren't having to get them early, there's not that family history of younger than age 50 breast cancers, is to start at age 40. Now, the reason this is also confusing, I know the Pap smear thing changed 10 years ago, and we're slowly getting that word out. But mammograms can be a little confusing too, and that's because there's not universal agreement. Everyone agrees that by age 50, you should be doing them annually. Some people say by age 40. It depends on which cancer society. If you talk to the radiologist or if you talk to a breast cancer surgeon. So ACOG, which is the governing body for OBGYNs, we say we can start as soon as age 40, no later than age 50, but between 40 and 50, it's between you and your provider. So it ultimately boils down to this. The reason there's question on should you do it 40 or 50 is mammograms aren't as great, I would say, as a test as you would think. They're not preventing breast cancer. They're trying to catch it early. And unfortunately, mammograms can lead to false positives, meaning I see an abnormality, now I had to get a lumpectomy or a biopsy of the breast. And so the younger you are, if you're 40, the breasts are likely more dense. You're more likely to have a false positive and maybe get an unnecessary biopsy. You also then look at when's the most time to get breast cancer. And 40 to 50, it can happen. 50 to 60, it's more common. 60 to 70, it's even more common. So as you get older, that risk goes up. So there's a lot of debate on it. But universally, it's safe to start as soon as age 40, definitely by age 50. I usually have a one-on-one discussion with my patients, and it depends on their family history and risk. But the way I look at it is it boils down to this. Getting a frequent, like annual breast exam starting at age 40, I would say if you get them regularly every year starting at age 40, you are going to be more likely to have a false positive and potential unnecessary biopsy, but you're also less likely to miss a breast cancer. If you wait till age 50, you're less likely to get a false positive or biopsy, but you're also more likely to miss an early breast cancer that could be developing in the 40s. So ultimately, between 40 and 50, it's a little bit of a discussion between me and my patients, or whoever you guys see in your doctor. But universally, everyone agrees by age 50 you should be. Most people still start at age 40 or choose their own adventure kind of pathway of maybe every other year or get a few during their 40s as long as they're seeing their doctor regularly. But ultimately, it boils down to that. And so, for example, my dad died of cancer in his 60s, and the type of cancer he got, there's the same kind of debate in men's health about prostate. But I'm going to choose a pathway that is on the more aggressive. I'd rather test to get a false positive than not test and miss something. So most people who choose to still go early, it's like, I'd rather test and get that false positive. Does that make sense? Any questions about that? It's gotten more confusing the more we've learned about cancers, but it also is the goal of it is to try to avoid unnecessary tests while still balancing not missing cancers. But yeah, starting at age 40 is recommended. And I think it's really between you and your doctor when you start. That's exactly right, Angie. So it's not wrong to start at 40. It's not wrong to start at 50. There's just pros and cons. And that's what I was trying to emphasize there. Okay. But self-exams, I think, is the biggest thing, because a lot of the women I know who have had or have been recently diagnosed or been through breast cancer, a lot of times they found it on their own at first. So while mammograms are helpful and an annual exam, I should say one more thing. It's every 1 to 3 years breast exam with the doctor. After 40, it's every year. So at your annual exams, we would recommend a breast exam every year. And that's great, but what about the other 11 months of the year if something came up? So it's really important, just breast self-awareness, pay attention to changes. If there's a persistent change that continues, don't ignore it, go get it checked out. Because you guys are your best advocates in this, and that you can catch something abnormal and go get seen. And if you go and we agree this is abnormal, it's not just mammogram, but sometimes it's an ultrasound of the breast to go look at that. And so that's how we try to catch things early. And the goal of catching early, of course, is to keep the stage lower and keep you safe. And if there is breast cancer, intervene as soon as possible. So as far as someone just asked, does breast pain after menopause mean anything? That's a difficult question to probably answer in general. But if you do have new onset of breast pain or changes, I would recommend getting checked out. It could have been a trauma to the breast or something like that. But if there's a new change in symptoms after menopause, especially when you've already been through menopause, I would get checked out. Okay, so that's the general. Obviously, there's all the other stuff with heart, lungs, thyroid, all those things. But those are the unique things to the OBGYN that we do a lot of is the pelvic exam and the breast exam. I want to talk a little bit about pregnancy, because once again, I don't know the age. I'm sure there's pregnancy age as well as postmenopause age people in the room, and I want to try to cover as much as we can in the hour we have. I will say, and I didn't get a chance to say this at the beginning, if someone is sitting in this lecture and realizes man, this is something I should get checked out, or I haven't been in for a while, I'm always happy to see any of you. At St. Mark's OBGYN. You can Google St. Mark's OBGYN or Google Sean Edmunds. If you called and said, you heard from me through this lecture, they'll try to get you in as soon as possible. Because if you're realizing, hey, there's something I've been ignoring and maybe I shouldn't be, or it's been a long time since I got an exam, don't hesitate to come in, because most importantly, we want to keep everyone safe and healthy, and so you can go about living your lives. Okay, so I'm going to talk about pregnancy for just a little bit. And I'm going to talk about some hot button things. When someone gets pregnant, we usually see in the office, depending on the provider, between 8 and 12 weeks pregnant. I choose to do 8 because that's usually when nausea is getting the worst. So I like to get people in the office, see them, do an ultrasound to make sure baby looks great, and that always reassures you when you're throwing up every morning. It's nice to see a heartbeat and know that this is worth it. We see early, and we see about every 4 weeks for the first 2 trimesters. And the third trimester, we see you more frequently, and that's because of higher risk for blood pressure issues, growth issues, things like that. But there's a couple things that always come up in these early OB visits that I like to kind of clear the air on. One is what can I eat? I feel like a lot of people feel like they're really restricted, and there's a lot of restrictions on diet and pregnancy. And the reality is this, a couple things on diet. First trimester, you don't actually need any extra calories, which is usually a good thing, because 70% of women are nauseous or thrown up. And so it's reassuring to know they're not hurting their baby if they're not quite getting as much as they think. Second trimester, you need about 300 calories, and third, you need about 400. So it's not as much as people think. And the reason that matters is weight gain is going to happen in pregnancy, but we want to keep you at a healthy weight gain. Which for most women is between 20 and 30 pounds. If you're overweight or obese, we try to keep it a little lower. If you're underweight, it might be a little bit higher. We just try to keep a healthy balance. The reason that matters isn't because if you gained 50 or 60 pounds that it was bad for baby necessarily, but we want women to be able to lose the weight afterward, because if you lose the baby weight, they've shown if you lose it in the first 6 months, there's a really good study that followed women at 1 year, 5 years, 6 months, 1 year, 5 years, 10 years, 15. Women who lost the baby weight in the first 6 months after were more likely to be normal weight 15 years later. Women who didn't lose the baby weight were more likely to be overweight. And so obviously if you gain 20 or 30 pounds, hopefully you're better able to lose that than if you had gained 50 or 60. So we watch that not because anyone should feel guilty, because I know some women who do everything right and they still gain 50 pounds. And it can vary depending on pregnancy, water retention. There's a lot of factors. But when we're talking in general, we're trying to keep you to a weight gain that's reasonable so that you can lose it afterward. Because my personal feeling on this is one of the biggest health risks to women related to pregnancy and childbearing years is, let's say someone has 3 kids. They gained a little too much with the first and didn't quite lose it all. And then they gain a little too much with the second, don't quite lose it all. And then third, and ongoing. And all of a sudden you're done having 1, 2, 3 kids, and you're 50 pounds overweight, 100 pounds overweight. And it just gets harder and harder. So keeping an eye on this during, which is why it's important to think about diet and weight gain. Now, as far as what is safe to eat, I think this gets way too complicated, especially if you get online, but you can boil it down to a few simple things. Meat should be cooked. Dairy should be pasteurized, because you hear all this thing about soft cheese, hard cheese, all these things, but dairy should be pasteurized, meat should be cooked. And the one unique thing on the meat is processed meats like lunch meats do carry a higher risk for foodborne illness and to someone who's immunosuppressed, which includes pregnant women. So if you love a lunch meat sandwich and you have the opportunity, we say zap it in the microwave for 10 seconds or something like that, and then it's safe to eat. But it doesn't have to be as complicated as it sometimes is made. The other thing that comes up is exercise, because when we're talking about staying healthy, a lot of women are told you can't exercise in pregnancy, or the 2 biggest myths I hear is you can't try anything new, or you can't get your heart rate over X amount. The most common number I hear is 140. Those are both not true. We recommend you stay active in pregnancy, because the reality is if you want a healthy, strong pregnancy, you want a healthy, strong you. And the best way to do that is to take care of yourself through staying active and eating right. Now, that doesn't mean that's going to be perfect the whole time, right? 70% of women, like I said, are having nausea or vomiting in the first trimester. Almost 100% of women are fatigued in the first trimester. The most common symptom of the first trimester is fatigue. The most commonly talked about is probably nausea and vomiting because it's miserable, but almost everyone gets tired. Second trimester, for most women, both of those factors tend to improve and you're able to be more active and feel a little more normal. Third trimester, obviously, as women get bigger, there's more limitations with physical activity just because of aches and pains and discomfort as the baby gets bigger. But trying to stay active through the pregnancy, either by keeping up exercises you did before, or maybe making some lifestyle changes, recognizing, hey, I'm growing a human, I want to be my healthiest version of me, is okay. So it is okay to start new things. The only restrictions I really put on people as far as exercise is listen to your body, for one. If you're causing a ton of cramping or discomfort, we don't want you hurting yourself. Or if there's ever bleeding, definitely stop. So listen to your body, but also, trust yourself and be willing to try new things. It's a great time to recognize, like, hey, I'm not just taking care of myself, I'm taking care of the baby, and it's okay to be active and get out there. And so doing that and exercising and trying to get sleep are big keys, just like they're keys in our normalized when women aren't pregnant and with men, is that good diet, good regular activity, and good sleep are huge pillars to our own health. And that's true in pregnancy. We work around all the trials that come with pregnancy and the lack of sleep that comes as you get more uncomfortable, but trying to stay active. I always tell women, if you can stay active and exercise, I can promise the pregnancy, the labor, the delivery, the recovery all go better. So we encourage people to keep that up. The other restriction that I didn't get to is just avoid an activity that we don't want risk you falling and hitting your belly or dropping. So if you're lifting heavy weights, you don't want to push yourself so hard that you could fall or drop something on your belly. And as far as physical activities, I get asked, oh, can I ski? Can I ride a bike? The reality is all those things are fine as long as you don't fall. And you can't guarantee that all the time with certain things, especially, for example, skiing with other people on the mountain or other sports. So make smart choices to avoid any trauma, but trust your body, listen to it, and take care of it. Any questions about that? Those are the hot ticket items I hear almost all the time, is exercise and diet. But it really boils down to being the healthiest version of you during pregnancy as well. I'm going to jump back. Sorry, Jamie Neverett, you asked a question about mammogram being unclear. And you basically said, if you're not comfortable with what the doctor thinks, should you push the matter? Yes. Doctors, nurse practitioner, PA, midwife, we're all human as well. I can promise that almost every provider I've ever met cares deeply about their patients and wants them to be healthy and do the best thing for them. But we're still human and we can make mistakes. A lot of times we don't get that same leniency because we're dealing with such serious matters. But if you're unclear on something, you're unsure, it is okay to press and say, like, I'm really still nervous about this. Or in worst case scenario, seek a second opinion if you're not on the same page with your doctor. So I hope that answered your question, Jamie, that you asked before I jumped on the pregnancy stuff. Any general questions about pregnancy? I just talked a couple big ticket items. I will put a plug in for St. Mark's Hospital. Amazing place to have a baby. I've been there for 5 years, and such an amazing women's health center, and great opportunities for whether someone's wanting a natural birth, epidural, a lot of different things. All right, I'm going to try to address this quick question of Allie. I hope you guys are okay if I do these. Oh, and great, you had your baby here as well. 4 months postpartum. But if I didn't stay active during my entire pregnancy, I wouldn't be in the shape I am now. Still some ways to go, but keep me happy. Okay, perfect. That's exactly what I'm talking about, Ali, is staying active throughout. It makes a big difference. It doesn't mean everything's going to be perfect. Everyone still has risks, but there's usually lower risk and people are a lot healthier and stronger, and you feel like you get back to where you want to be afterwards. So, but I'm glad you had a great experience at St. Mark's, since I was just vouching for us. Okay, so take a step back from, we talked about the Pap Smears, the pelvic exam, the mammograms and breast exams. Talked a little about common questions I get in pregnancy, and really just my soapbox of take care of yourself. I want to transition to, same thing goes for our general health. This year has been crazy. I've never done a WebEx talk, and I hope you guys are getting something from this. I'm glad we have the chat box that you can throw things out there. But yeah, this year has been crazy, and I think oftentimes we underappreciate the importance of or we don't give enough respect to the importance of our mental health. And so when I talk to someone about general health, I already talked to you a little bit about the 3 pillars of diet, of a healthy diet. And by diet, I do not mean restrict yourself and starve yourself to lose weight. I mean healthy food choices to make real life change that are sustainable. And I'm going to talk about that in a second. Exercise and sleep. But the 4th is just our mental health. How are we doing? Let's see, Becky Timothy, do you need a COVID test to get a lump checked out at St. Mark's? No. If you need an exam to be seen, you do not need a negative COVID test. We're still seeing people. What happens when you come to our office is you come to the women's pavilion. At the entrance to the women's pavilion, everyone gets a temperature scan and a screen for symptoms. And then you come to our office, which is on the 4th floor, and you'll probably get similar questions again. Obviously, if you're feeling sick or having a fever, we're asking you to be responsible to everyone else's health as well, and not come out. But if someone needs an exam, you do not have to have a negative COVID test to come see us at the office. You will get temperature checked, and we're asking you to be responsible with symptoms. We're asking you to wear masks. But no, if anyone has a question of anything, you can still come to us. You don't have to have a negative test to do that. Okay, so back to the general health is, this exercise, how you eat, getting sleep, but mental health. And I think I've seen a lot of change in this last year or two of people recognizing the importance of that. Unfortunately, because I think mental health has suffered. Patients that I have that have a history of anxiety, depression, this year's been harder. Patients that I have that don't have that history, also been harder. I've had more talks about anxiety and depression in the last 8 months than I had in the past 5 years. And so it's important that we look at all these things, that we look at our whole body, because unfortunately, when mental health suffers, our physical health suffers, either by not taking care of us, or there's this thing called somatization where depression or anxiety can actually lead to physical manifestations. And so if anyone's ever been told by the doctor when they're having chest pain or some other thing, maybe it's anxiety, it's not meant to blow them off, but you can really have these physical manifestations that are a struggle. And so we want to really focus on taking care of those things. So my soapbox there is exercise. How often is recommended that someone should exercise? Anyone know? What's the general recommendation? And is it different for pregnancy? 150 minutes a week. That's, yeah. But essentially, they say, moderate exercise. The goal is 30 minutes a day, 5 days a week. I love every day, really. I mean, come on. That's a great comment. So the goal is regular exercise on most days of the week. And the wording is a little different for pregnancy versus non-pregnancy, but it's really the same. And now I don't want to saying 30 minutes every most days of the week of moderate exercise. Maybe that's too much for someone in this room, and that's totally fine. If you realize I don't exercise, but I know I need to start, unfortunately, some people sign up for a gym and you go to the gym and it's intimidating. You don't know where to go, what to do, or where to start. And so you walk to the treadmill and you start on the treadmill, but that's fine. Start someplace. Start on a walk in your neighborhood at night. But if you can work up to at least 30 minutes a day, most days of the week, then great. And that starting point is going to be different for everybody depending on your own health level. But the best thing we can do is all support each other in that and push for it, because if we're talking about health risks, staying at a healthy weight and being physically active lowers your risk of many things drastically. If you look at women's health alone, obesity makes you higher risk for urinary incontinence, higher risk for heavy irregular periods, higher risk for infertility, higher risk for breast cancer, colon cancer, gynecologic cancers. And so doing what you can wherever you're starting at now to be active is key. And as you get active, let's say you're starting with just walks, a key would be not only just some sort of activity, but also mixing cardiovascular with resistance training, whether that's bands or weights or body weight. To do resistance training is really key as well. So a mix of those two. And then diet. I hate the word diet has become synonymous with starvation or restriction, but really a healthy diet is about eating a well-rounded healthy diet all the way around, which involves carbs, fats, and proteins. Now, if you don't know where to start with that, there's professionals out there, nutritionists, trainers who are good at diet, things like that. But it's just a matter of waking up to these things and following it. All right, so I have a question here, question about pregnancy and COVID. I'm in the second trimester, sometimes fearful of COVID and the risk for my baby if I were to get it. Do you have any information? Yes. So let's talk about COVID for 2 seconds, and then maybe I'll just open up the rest for questions. COVID's caused a lot of fear, unfortunately, right? And part of that is because we don't know as much as we'd like to. Now, some people have said that fear is so much that then there's been this pushback of not wanting to wear masks and all this, and this has become way too political. But the reality is, it's a virus. The best thing we can do for each other is protect each other by wearing a mask and social distancing until we get further along with interventions like vaccines and we learn more about it. But as far as pregnancy specifically, Jane, luckily it's been around just long enough, especially like in China and other places, that there have been women who got pregnant since the outbreak and have delivered and have had COVID. Luckily, we're not seeing birth defects, like, for example, with Zika virus. Luckily, most pregnant women, because you're at a healthy age, usually of between 20 and 40, you're considered in a lower risk category for serious illness. And for most pregnant women, that continues to be true. Now, even as an OBGYN, the data kind of is back and forth. And that's what happens when something's new, is there's all the data is pouring in and we're trying to interpret it. But you don't have to be afraid. What I would say is this: follow the public health guidelines, but live your life still. If you got COVID, the likelihood that anything bad would happen to baby is we think low. We don't see birth defects. We don't see changes like that. Now, unfortunately, if you're in the small percentage of women in your age group that actually get sick or become hospitalized, because in pregnancy you are immunosuppressed, you have the risk of it being worse. So the risk of potentially being in the ICU or something like that is higher. Now, luckily, most pregnant women we've seen, I can speak for at St. Mark's, we did have one pregnant woman in the ICU early on in the process. She had comorbidities, meaning morbid obesity and some other health issues related to that. But the vast majority of women who have got COVID comfortably recover at home like they had a virus. So I don't want you to be afraid. I want you to be smart, take care of it, protect yourself, but not afraid that there's going to be any major risk to your baby as long as you take care of yourself. All right, next question. Do you approve of intermittent fasting? Not in pregnancy, of course. Do I approve? Yes, because I approve of anything that works for the person as long as it's not pushing to extremes that are dangerous. Intermittent fasting, for those asking, there's a few ways to do it. And Laura, maybe you have a specific way, but some people choose intermittent fasting, meaning they only eat like a set amount of hours during the day, and then they don't eat between 7 at night or 7 the next morning, 12 hours where they eat, 12 hours where they don't. Some people do it as a once a week they fast for the day, but do I approve of it? Yes. And here's why. Diet has become like synonymous, like I said, with suppression and this is the only way to do it. But there's a lot of different ways, and you got to find that works for you. And if intermittent fasting has worked to keep you at a healthy diet and help you or healthy weight and activity, then great. And that should be fine. And that could be through any life stages. It's true that we wouldn't necessarily recommend it in pregnancy, and that's because the baby is always having that glucose need. So typically small snacking throughout the day is, depending on parts of pregnancy, intermittent fasting wouldn't work well. But I hope that answers your question. All right, do blood clots from COVID affect the placenta? So what has been shown, especially if there's more severe presentation of COVID, is there's a high risk for blood clots. Now, when you're pregnant, your estrogen levels are way high, and high estrogen levels are associated with the high risk for blood clots. Just like taking a birth control pill, the high risk for blood clots in your legs and things like that. So there is some evidence suggesting that if someone's sick with COVID, that should they be on a blood thinner. Now, there's still data forming on that. Now, as far as affecting the placenta specifically, probably don't have a good answer for you there. But if someone is seriously ill with COVID, especially if they're hospitalized, we'll usually put them on a blood thinner to lower the risk of blood clots. All right, so Jane, I follow the recommended guidelines from the good to know. Thank you for addressing. No problem, Jane. Thanks. Okay, and then I've got another question. I have out of control diabetes and obesity. Okay, so I think that's great. If you have a health issues you're trying to address, especially if they're more serious or out of control diabetes, I would coordinate with your primary care doctor on those. But things working to lose weight in a healthy way, in a sustainable way, are great, and I hope that works well for you. What I would say about this, and a 2 cents on weight loss here, is a lot of times you hear people, the yo-yo diet, meaning you're kind of back and forth on your diet, or the yo-yo weight loss. You lose 20 pounds, you gain 20, you gain 30, you lose 40, and a lot of people have either dealt with this or seen a family member deal with this. Here's the issue with weight loss. Your body has a metabolic set point that it wants to sit at. So when you start to lose weight, it doesn't matter if you're 400 pounds, 300 pounds, 200 pounds, 150 pounds. If you're trying to lose some weight to be at a healthier weight for your body, your height, and your body type, your metabolism slows down to try to keep you. So let's say you're 300 pounds up here, but you lost down to 280, 270. Your metabolism doesn't move as fast as your weight loss. What they've shown is your metabolism takes a full year to catch up. So if you lost 20 pounds, 40 pounds, 50 pounds, the issue is people who lose it really aggressively through starvation or excessive exercise. You get down, you feel so great about it, your metabolism fights you. And then, so if you aren't doing something that's sustainable, you're more likely to bounce back up. You have to keep that weight off for a full year for your metabolism to slope down and catch up with you. So think of your metabolic set point. And if someone's trying to lose weight, the reason we argue slow and steady, even though none of us are patient enough, we want it fast, right? And we hit that point where we want to change our life and we want it fast. But Slow and steady, like 1 to 2 pounds a week, is more sustainable, because pushing yourself too hard leads to that slow metabolism, hungry all the time, miserable, trying to keep up, and you're more likely to rebound. So wherever you're at, whether you're recently postpartum, whether you're morbidly obese, start slow but stay consistent. Choose plans that work for you to help you stay consistent with that. And losing weight will help with diabetes, heart disease, a lot of other things. Just getting to a normal weight will make a difference. Okay, I'm going to try to get through a couple more questions because we're almost out of time. Partial hysterectomy, what is the recommendation on PAPs? So that's a confusing question, only because the lay public calls a partial hysterectomy different than we do. To a doctor, a partial hysterectomy to me means the uterus was removed, but the cervix was left behind. Now, this is not a common way to do a hysterectomy anymore. It got popular in the 90s and 2000s because they thought it would make sexual function better by leaving the cervix behind. But what it involved is either needing to make a big incision on the abdomen or morcellate, where you chop the uterus up and pull it out through the tiny ports if you want to stay minimally invasive. So you leave the cervix behind. So if the cervix was left behind in the true form of what a partial hysterectomy is, you still need to do Pap smears because there's still a cervix. Now, partial hysterectomy, the way most people think of it outside of the medical profession, though, means, oh, they removed my uterus, but they left my ovaries. Now, we do that different. The hysterectomy is just uterus and cervix, but the ovaries, it's actually called an oophorectomy. Just nobody knows that term, and it's a weird word to say. So you get this partial versus complete. So if someone has any remnant of their cervix left, you do need to keep up Pap smears. Now, if someone has a traditional hysterectomy where they completely remove the uterus, including the cervix, which means the top of the vagina doesn't have a cervix there, but where the hole is, it's just a sutured line across. So you do not need a Pap smear as long as you had normal Paps. But if you have a history of abnormal Paps, we still do the Pap smear. And what we're doing with that brush, instead of brushing the cervix, we're brushing what we call the vaginal cuff, the top of the vagina, because that HPV virus that caused your abnormal Pap once upon a time can cause vaginal dysplasia or cancers, and it can cause vulvar dysplasias or cancers, which is why when we do a pelvic, it's not just a Pap. We're looking at the skin and all that as well. But if you've had a history of abnormal Pap smears, we still Pap the top of the vagina. And depending on your degree of abnormality, that's kept up for a number of years, and then eventually between you and your doctor stopped. I hope that answers your question. But yeah, if there's any cervix remnant, you would still do it. And that would, some people are unsure, but that was something that could be easily determined on an exam. Now, we don't typically leave the cervix anymore unless you kind of had your hysterectomy in that time frame. The reason being is because it didn't prove to help with sexual function. If a hysterectomy is done appropriately and there's good suspension, vaginal length should be normal. Sexual function should be normal as well. Let's see, and then Paige. Thank you for being nice to me. Nice comment. Let me scroll down.
Sorry, I don't have a chat in my.
Oh yeah, let's hear it. Go ahead, Jamie.
Really quick, one thing is what about those people that deal with being underweight, and how that affects like getting pregnant or things like that? And then also, if you have a family history of postpartum depression, is there anything that you can like do about that?
Yes. So being underweight, depending on the degree of underweight, if you're underweight to the point that your periods are irregular, that will make getting pregnant more difficult. The reason being with being severely overweight, or if you're underweight, can lead to hormonal changes. What should happen when someone cycles is the estrogen progesterone spike, you ovulate, and then if you get pregnant, great, hormones stay high. But if you don't, within about 14 days of ovulation, the hormones drop, and then the period comes because the lining destabilizes and your body starts over. So if someone's ever irregular, for example, like with being underweight, if your periods are irregular, that probably shows that your hormonal function's not where it should be. Because if the period's irregular, it usually means the ovulation is irregular. So in that setting, that it needs to be a one-on-one, but there's usually some some blood work to do, some discussion of how to be at a healthy weight, and sometimes hormonal medications that are given to help with that. But that would be something like you could see your provider, or someone could come see me for, and that's something we take care of regularly. As far as depression, now depression is tough. There's a lot of genetic components as well as environmental components to depression. With a family history of depression or postpartum depression, is there a higher risk for postpartum depression? Yes, there is. Also, if someone has a personal history of depression, is there a higher risk of postpartum depression? Yes, there is. So the best thing you can do is proactive monitoring, open discussions with your partner, open discussions with your family and with your doctor. So if I have someone who has a history, personal or family history of postpartum depression or regular depression, we're usually very conscious of it. We keep open dialogue. And we try to start with lifestyle things that can help, therapy with trained professionals, and in some cases, medications are needed. So we try to be more on top of that because we're getting better at recognizing it and talking openly about it. But depression's been one of those things historically that was kept in the shadows, which was the worst place for it to be. And being open with the fact that depression can be common and that 20% of postpartum women can get depression has helped open that door for more discussion and better health and less complications from getting severe or out of control. I hope that answered your question, Jamie. I'm going to jump to these others, and I know some of you may need to hop off. I'll stay on a little bit longer to try to get through some of these questions. Someone mentioned a food log. That's a great way. Like I said, just don't starve yourself. Be smart about what you're doing, and as long as it's helping you make healthy choices. Someone said, if you've had a hysterectomy, why do you do a yearly exam? Because the uterus is only one part of your body, and we still check your heart, lungs, thyroid, your abdomen. If you still have ovaries, we want to check for ovarian masses. If you're getting older, we want to check for any risk for vulvar cancers, and we want to look at your whole body. The uterus is just that one part of you. If you've had normal Paps always, you don't need an annual Pap smear or an every 3-year Pap smear. But if you had history abnormal, you're probably being tested differently. Tips or tricks for a remedy of hot flashes. Now, sometimes you just need estrogen. You go through menopause, your estrogens tank, and it leads to these hot flashes, vaginal dryness that cause pain with intercourse, moodiness, things like that. So there are over-the-counter things like black cohosh, but it really just acts on your estrogen receptors. There's formulations and things that you can buy, and they are usually for mild symptoms. But ultimately, if you're struggling with hot flashes, sometimes getting on an estrogen replacement, either temporarily or long-term, is the key. And that would be individualized to the person, but that's something you can easily come in for. Okay, recommendation for someone to have the thyroid removed because of nodules, what things to watch out for after. If you don't have a thyroid, then you're taking thyroid replacement medication. That should be something that's regularly screened, especially with your annual exams, or more frequently if you're adjusting your medication. But having too much thyroid is associated with heat intolerance, sweating, bulging eyes, racing heart, too much weight loss. Having too little thyroid, and this is true for someone who's had it removed or someone who has one and just wonders, too little thyroid, like your thyroid's not making enough, is usually cold intolerance, weight gain, obesity, depression, sleep disturbance. So one of the first things I check if people are having weight fluctuations or any of those kind of symptoms is we screen the thyroid and treat as needed. How much calcium should I take each day to maintain health? Ooh, that is a very tough question. There are daily calcium supplements. Overuse with some people could put you at higher risk for kidney stones. So as a premenopausal woman, probably adequate to take what's in a prenatal vitamin unless you're having symptoms associated with low calcium. And afterward, it might have to be individualized by the person. So I probably, unfortunately, Connie, can't give you a perfect answer on that one. I'm sorry. Say hi to Marilyn for me. Marilyn Love, I'm assuming who's you're talking about, Candy, is no longer with us, but I keep in touch with her. She's a great person. Oh, sorry, that was a private message. And then one other thing came up about PCOS. We won't have time to talk about that today. Polycystic ovarian syndrome is a condition of hormonal irregularity. It's a very common cause for menstrual irregularity, fertility issues, and associated with obesity and weight issues. So that is probably a whole hour discussion. It's very complex. And if anyone has that and is not doing something about it, come see me, because we can get you at a better spot, a healthier spot, so you can be the healthiest version of you. I think we're out of time. Thank you for all of you who hung in here. I don't know if you're working from home or offices or where, but it's so great to see you. Can you please provide your contact? Yes. So Sean Edmunds, our office number, I guess I can type this too. I can use this. Oops, hold on. Sean Edmunds at St. Mark's OBGYN. Our office number is 801-268-6811. Our website is stmarksobgyn.com. I'd love to see any of you in person and help you be your healthiest selves, whether it's pregnancy related or not. I do a lot with pregnancy, but I do a lot of other things as well. And if you're having irregular periods, problem periods, stress incontinence, leaking urine, I mean, don't put up with these things. You guys put up with way too much stuff. Men would be complaining like that. But don't put up with stress incontinence. Don't put up with, if you're not happy with where you're at with weight or life or lifestyle things, or if your periods are out of control, we can fix most things. So come see us. So great to see you all. Have a good day.
Thank you so much, Dr. Edmunds.
So
That was
much.
wonderful.
Yeah, I'm happy to come back anytime. I'm glad this worked out so well. We got good participation, and take care, guys. We'll see ya.
See you later. Thank you.
Bye.